1/3 of patients consulting a primary care physician suffer from problems related to the urinary tract system. Especially elderly people can experience various diseases which can cause urinary retention and, even worse, hydronephrosis. Ultrasound is the most accurate tool to detect urinary retention, to diagnose the underlying pathology, and to evaluate if complications are present. Importantly, ultrasound allows us to detect hydronephrosis at an early stage. This is important because we need to initiate treatment as soon as possible. Clinical signs and symptoms of hydronephrosis are often misinterpreted. Instead of opting for primary care ultrasound as a first step, patients often undergo MRI and other costly examinations. These methods not only delay diagnosis, but can also be harmful. In the following lecture, Dr. Martin Altersberger from the Medical University of Vienna will talk about the use and importance of primary care ultrasound. You will learn how to image the kidneys as well as the urinary bladder, and how to detect and grade urinary retention and hydronephrosis.
Did you know that humans spend over 22 days in one lifetime urinating? Urinating is a very important part of your life. In this lecture, we are going to evaluate the normal anatomical findings of the urinary tract, including the kidneys and the urinary bladder, and we are going to evaluate pathological findings like hydronephrosis and urinary retention with the help of primary care ultrasound. Let's start with the kidneys. On the right-hand side, you see a perfectly normal, healthy kidney. And I'm sure you have already seen the problem on the left-hand side. This echo-free space, this is hydronephrosis. Second, we need to evaluate the urinary bladder. On the right-hand side, the depth is only 12 centimeters. On the left-hand side, just look, 18 centimeters. There's a whole lot of difference in those two pictures and the filling status of the bladder. On the left-hand side, we already see urinary retention. To understand these conditions, we need to take a look at possible causes. Causes of hydronephrosis are various: stones, carcinomas, for example, prostate or cervix carcinomas, congenital abnormalities, aneurysms, endometriosis, pregnancy, coagulation of blood if macrohematuria is present, and various rarities like pelvic lipomatosis and ovarian vein thrombosis. Causes of urinary retention again are various, beginning from stones, of a medication, neurological causes, for example, multiple sclerosis, gynecological causes, carcinomas, and finally, hyperplasia of the prostate, which is very common in elderly men. With so many possible causes of hydronephrosis and urinary retention, I think we need to break it down to an essential message and just simplify it. The patients will show up in your office with abdominal pain. You might think there are so many possible causes for abdominal pain too, but keep always in mind, common things are common. 1/3 of patients presenting in a general practitioner's office or in an ER department suffer from non-specific abdominal pain, so no organic reason can be found after examination and baseline investigation. Nearly 1/3 of pathologies are related to the urinary tract, and the rest are various other causes like cholecystitis, appendicitis, gastroenteritis, and many more. Additionally to abdominal pain, there are more signs and symptoms in patients with acute urinary retention. They are oliguric, even anuric, they are sweating, they are hypertensive, and sometimes they don't even have control over the bladders anymore. Physical examination alone can only give a hint to get a diagnosis. Without further information like lab tests, x-rays, or ultrasound, it's more like guessing. Lab tests do cost a lot of time. With x-rays, there's always the problem of radiation. But with the help of primary care ultrasound, you will get an accurate and fast diagnosis. Before we perform an actual ultrasound examination together, let's have a look at the anatomy, starting with the liver. The liver is cranially to the right kidney. We can remove it. We can remove the stomach and all of the intestines to get retroperitoneal, where the kidneys are located. The right kidney over here, the left kidney over here. Cranially, the left kidney, you see the spleen. Cranially, the right kidney normally is the liver. Both kidneys are sliding on the psoas muscle during inhalation and exhalation of the patient. You see the ureters form out of the renal pelvis. And if we take a closer look at the renal anatomy, you can see renal parenchyma, mark pyramids, the renal papillae, which are the connection to the minor and the major renal calyces. The ureter drains the urine from the kidneys into the bladder. The bladder is located behind the pubic bone, and depending on the gender, inferior to the bladder, there's the uterus or the prostate. After this anatomical excursion, let's continue with the standard views of an actual ultrasound examination. Before the actual protocol, it is very helpful to know the normal findings. Here you see a normal kidney. It should be bean-shaped, 10 to 12 centimeters in length. The renal pelvis should be hyperechoic, as you can see here, so very bright. The kidney should slide on the psoas muscle, and there should be no dilatation of the renal pelvis. The bladder should be completely echo-free. Be aware, due to normal physics, artifacts can occur. The most important thing is, remember there should not be any kind of free fluid. In between the bladder and the prostate here, the so-called Bruce cavity, or in the Douglas cavity in women. The first standard view is a longitudinal axis of the right kidney. Place your transducer in the right side of the patient, mid-axillary line, below the rib bow. Here you can see the kidney nicely in the center, renal parenchyma, renal pelvis, hyperechoic. Cranially, the kidney is the liver. In between the liver and the kidney, the so-called Morrison's pouch. The kidney is sliding on the psoas muscle. The renal parenchyma should have the same echogenicity compared to the parenchyma of the liver. To get the perfect transverse view of the right kidney, rotate the transducer around 90 degrees counterclockwise. The marker should point to the right side of the patient. And here's the view you will get. Kidney in the center again, renal pelvis hyperechoic, renal parenchyma, Morrison's pouch, and the liver cranially. To get the optimal image of the left kidney, place your transducer in the mid to posterior axillary line below the rib bow. Marker is pointing cranially, and sometimes it could be necessary to rotate the transducer a little bit clockwise to get an optimal image. Here's what you will get. The left kidney in the center, renal pelvis hyperechoic again, renal parenchyma, kidney sliding on the psoas muscle, and cranially to the left kidney is the spleen. In between the left kidney and the spleen is the so-called collar pouch. To get the transverse view, same as on the right side, turn the transducer around 90 degrees counterclockwise. You will get this image. Left kidney in the center, hyperechoic renal pelvis, renal parenchyma, a greater extent of the spleen, and here's the collar pouch. During the hands-on section, I will show you in detail how to tilt and rotate the transducer and how to sweep through the whole organ. In case of the bladder, there are two standard views you need to remember. Start at the midline of the patient, placing the transducer in a transverse suprapubic view, marker is pointing to the right side of the patient, and a longitudinal suprapubic view where the marker points cranially. Those are the images you will get. Keep in mind to tilt the transducer caudally and cranially and to the left and to the right to see the whole extent of the organ. Another very helpful feature if you want to detect urinary retention is to measure the volume of the urinary bladder. You have to measure the depth and the width in a transverse suprapubic view and the length in a longitudinal suprapubic view. Multiply them and divide it through 0.7 and you will get the volume of the urinary bladder. It should be in between 250 and 500 milliliters. Here you see 400 milliliters. This is perfectly fine and perfectly normal. Let us move on to the most amazing part of this lecture. It's hands-on time. We are going to do a very important part in medicine now. We are going to examine a patient. We are doing this with the help of ultrasound. We are using a handheld ultrasound device with a dual probe, a phased array transducer, and a linear transducer. We are going to use the phased array for kidney and the bladder. I'm going to give you some very good tips and tricks and an easy approach that you will always find the bladder and the kidneys. You might ask yourself where to start when I'm looking for urinary retention. I'd suggest start right away with the bladder. If the bladder is really filled, it should not be a problem to visualize it. We place our patient in a supine position and put the phased array transducer suprapubic. And we already get a good image in the center of the bladder. Now with a little bit more depth, we also see uterus and rectum. What's really important is that you scan the whole bladder to see where's the maximum extent. So tilt the transducer caudally and cranially. The bladder should be completely echo-free. You see some echogenic structures inside the bladder. Be aware, this could be artifacts. Other differentials are stones, maybe a tumor, or blood inside the bladder. But as we see here, this is a completely echo-free bladder with some artifacts only. We adjust the depth a little bit. Now freeze the image and measure the volume of the bladder. Be aware that if the bladder is really full, it can be quite hard to get it on one image. So you have to measure what you get. So now we saw a transverse view of the bladder. We rotate the transducer clockwise until it points cranially. And again, we tilt and move the transducer a bit in a longitudinal plane to get a good overview over the whole bladder. Also to the left and to the right. Again, we see some artifacts right there. Be aware, sometimes they are there. Freeze the image and continue the measurement. We saw that the bladder is way larger, so we get around 440 milliliters. It will be even more, but you get the idea, this bladder is quite full. Now we have seen the whole examination of the bladder. It's time to move to the kidneys. For the left kidney, as I told you, we are using the sector probe. But first we need some gel. We place the patient in a supine position, the hands raised over her head, and we place the transducer in the mid to posterior axillary line because the left kidney compared to the right kidney is a little bit more dorsally and cranially. So at first we take a look at the picture we see now. We see belly and belly gas. Now we can ask our patient to inhale deeply and hold her breath. Now we can try to really find the kidney properly. We see in the center already the kidney, but this is not an optimal view. We are going to adjust the depth a little bit. So now we have the kidney closer and maybe move a little bit more cranially. Here we already get a good image of the kidney. Now we can also try to rotate the transducer clockwise to really get in between two rib spaces. This will make it really easy to get a good view of the kidney. Now as we have the anatomy, you can continue breathing, thank you. We see the left kidney in the center. We see the renal pelvis hyperechoic, around it the renal parenchyma and also marked pyramids. Very important, we also see a little bit of the spleen and the space in between the spleen and the left kidney, which is called the Colles pouch. Very important to visualize if you want to look for free fluid. In the case of a hydronephrosis, we will take a closer look at the hyperechoic renal pelvis. In case of a hydronephrosis, it would be hypoechoic. So again, and take a look at the kidney. Again, inhale, please. So we tilt also the transducer in a longitudinal plane to get a good image of the whole kidney. You see sometimes if the ribs are in our way, it's quite hard to see the whole organ. To help ourselves even more, we rotate the transducer counterclockwise around 90 degrees. We lost the organ a bit, so we just continue to go back to the longitudinal plane. We rotate the transducer counterclockwise. Now that we see a transverse view of the kidney, we can evaluate again the renal pelvis in the center, which is hyperechoic, and the renal parenchyma, and we tilt the transducer cranially and caudally to really see the whole organ. To conclude, it's really important to let your patient inhale and exhale to get the optimal view of the left kidney. If this is not enough, you also can place your patient in a right lateral position for the left kidney. This is covered in the lecture on the kidney. Now, for the right kidney, we again place the patient in a supine position. And can you raise your hand behind your head? Thank you very much. So, compared to the left kidney, normally imaging the right kidney is way easier. So we start the same, place the probe in the flank of the patient mid-axillary line, and we already get a glimpse of the kidney cranially. Now we only have to adjust the depth. Please inhale now. As she inhales, you see the kidney sliding over the psoas muscle, and now we have the kidney in the center of our image. Now we can freeze the picture, also measure the length of the kidney as good as possible. Sometimes not the whole organ is seen in one picture. And take a look at the renal pelvis for hydronephrosis. Now it's hyperechoic, the way it should be. If it's hypoechoic, think of hydronephrosis. For a transverse view, again, inhale please. We rotate the transducer 90 degrees counterclockwise and keep the right kidney in the center of the image. And now tilt cranially and caudally to visualize the whole organ. Another important anatomic structure in this view is the liver. And in between the liver and the right kidney is the so-called Morrison's pouch. Like the collar pouch, fluid often accumulates in this recessus. You have seen an entire examination of the urinary tract. Two more really important tips. If the patient experiences any kind of pain in the region you are examining, this could be a very important clue for the final diagnosis. And the last and most important thing, practice. The more you practice, the better you will get. You have seen how to image the kidneys and the urinary bladder. Now I will show you some tips and tricks I use in clinical practice to get just perfect images. First, be sure that you're orientated correctly. The liver on the right side, seen here, the spleen on the left side, are used as a scanning window. Therefore, try to keep the liver cranially to the kidney, but the whole kidney in the center. Here you see only the cranial pole, here the caudal pole. Really try to focus that the kidney stays in the center of your image. The second, and I think most important tip in nearly any kind of abdominal ultrasound examination is that your patient inhales. Here you see a lot of bowel gas. It's blocking our view. As soon as the patient inhales, you see the kidney is appearing in the center of the image. Here you can see nicely, patient is inhaling and exhaling. The kidney is sliding over the psoas muscle, and as soon as the patient inhales, the kidney is in the center. Another important feature is the depth setting. Normally it is in between 10 to 15 centimeters. It can vary greatly depending on the physical status of your patient. Here you see the kidney is very close to the transducer. Here you lose a lot of information. On the other hand, if it's too close, a depth setting only of 8 centimeters, you won't see the whole organ. So try to find the depth setting where you see the whole organ you want to image. The gain setting is also very, very important, if it's too bright, too hyperechoic, you will lose a lot of information because you can't differentiate the anatomical structures anymore. On the other hand, on the right-hand side, if it's too dark, you won't see the region of interest at all anymore. So try to find a setting where you see an optimal gray and white scale. Apply those tips to your clinical routine, and in over 95% of your patients, you will get just perfectly fine images. Here you see a perfect longitudinal view and a perfect transverse view. Still, in some situations, you might need one extra image. Where to go now? Go cranially and try to find an intracostal approach. Here you can see nicely the cranial and the caudal rib, and in between the kidney. This is not a standard view, but an extra opportunity to get even more information. In the standard protocol of scanning the bladder must be full. If the bladder is full, you can differentiate, is the bladder wall thin or thick, or is it smooth or not. In case if the bladder is too empty, you can misinterpret the bladder wall. Here it looks rather thick. And if the bladder is empty completely, it's even hard to find, like in this case. You have seen the normal healthy anatomy. I showed you some tips and tricks. Now it's time to evaluate the pathological findings. I want to show you such a case right away. Here you see a transverse view of the kidney. Here you see dilated renal pelvis and renal calyces. I would have said grade 2 of hydronephrosis. But if you take a look at this longitudinal view, you see again the dilatation of the renal pelvis and the calyces, but also a narrowing of the renal parenchyma. This is grade 2 to 3 hydronephrosis. I graded it like that and described the renal parenchyma. 2 more cases of hydronephrosis for you. On the left-hand side, you see a dilatation of the renal pelvis and a dilatation of the renal calyces with a narrowing of the renal parenchyma. This is a clear case of grade 3 hydronephrosis. On the right-hand side, you see a dilatation of the renal pelvis and the renal calyces too, but no narrowing of the renal parenchyma at all. A very clear case of grade 2 hydronephrosis. 2 more cases. On the left-hand side, I'm sure you have already seen hydronephrosis is present. In the center, you see the dilatation of the renal pelvis and the dilatation of the renal calyces. But what about the right-hand side? In this case, it was very tricky for me. I had to tilt and rotate the transducer a lot. I had to move my patient. But then I got this perfect picture and proved hydronephrosis grade 1 is actually present. Here you see the dilatation of the renal pelvis. What is urinary retention? Urinary retention is defined by a bladder volume over 600 milliliters, a filled bladder with hydronephrosis present, and a filled bladder with no urge to urinate. Let's start with the first case. Look at this huge bladder. This was a patient experiencing lower abdominal pain and had no urge to urinate. This already is urinary retention. Let's take a look at a second case. Do you see this enormous bladder, even bigger than the first one? Note those little echogenic spots inside the bladder. And with color Doppler you see a so-called twinkling, a rapid change in red and blue color. I will tell you shortly what twinkling stands for. But first, let's measure the bladder. It was very huge. I did not get it on one picture. I measured around 700 milliliters. Because of this enormous bladder, I was sure this is an underestimation, but urinary retention was proven definitely. I placed a catheter, and 1.5 liters of urine with many small urine stones inside were removed from this bladder. The stones actually caused the twinkling. Normally, twinkling occurs in kidney stones or in gallstones, depending on the composition of the stone. Let me introduce to you some of special cases I acquired in my daily clinical routine. An 80-year-old female patient with abdominal pain enters my office. She states that she has problems with urination. I think uncomplicated cystitis, but because of the abdominal pain, I performed an abdominal ultrasound examination. Those were the first 2 views I got. Is this hydronephrosis already a complication? Remind what I told you before. Tilt and rotate the transducer to get more views. Here you can see quite nicely, no, it's not hydronephrosis. Here you can see the renal pelvis hyperechoic. Here again, no dilatation of the renal pelvis. And here again, no dilatation of the renal pelvis. What are those black areas? They look like cysts. No hydronephrosis is present, but the cysts need a workup. This is a case of an 82-year-old patient. She was in the hospital. She was released 8 days ago, and she complains of progressive dyspnea. In her physical examinations, she seemed completely dry, and she complained of left-sided flank pain. She must have been in the hospital because of pyelonephritis. Therefore, I performed an abdominal ultrasound. Here you can see on the left-hand side, the right kidney of the patient, completely normal, except one small cyst is seen over here. On the right-hand side, on the other hand, you see a dilatation of the renal pelvis. Hydronephrosis is present. Because of a history with progressive dyspnea and my findings in abdominal ultrasound, I decided to perform an ultrasound of the lungs to detect a very serious complication of renal failure, pleural effusion. Here you can see all those black spaces here and over here. This is pleural effusion, free fluid inside the thorax. Another very important and dangerous complication is pericardial effusion. In patients with renal failure, always take a look at the heart. Here you can see the right ventricle and the right atrium. Primary care ultrasound is of great value in detecting hydronephrosis and urinary retention. Follow the standard protocols, but always be ready to improvise if standard views are not accessible or if complications occur.